Oh, how was it?
Very good indeed.
Oh, that's nice. Yeah, here in Ecuador, there are a lot of people that are interested in going there to some hands-on courses. So it will be nice if you can give us, when is the next one, or the other ones that we'd love to go.
With pleasure, we'll do.
Thank you, Professor.
1 minute, just give me a second here. I gotta put the finishing touches on putting it on YouTube. Because that's actually where most people will see it. Okay. Hey, we are live on YouTube. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett, televising from Miami, beautiful Miami Beach in Florida. We are hosting once again Yemen. We did a lot of Yemen Walter Dandy webinars, but this one's a combination of Portugal and Italy, as well as the host Yemen. And I'll turn it over to the irrepressible Ahmed, who put all this together. Welcome, Ahmed.
Hi, dearest John. Here is Ahmed Al-Ghanimi, the president of Walter E. Dandy Neurosurgical Student Club of Yemen. I'm also a marketing administrator at Abdul Rauf University of Neurosurgery, which is considered the first online academic degree in neurosurgery worldwide. It is my pleasure and honor to introduce Professor Ibrahim Sbeh, who is the past president of the Pan-Arab Neurosurgical Society and the Jordanian Neurosurgical Society. He was also the president of the vice president of the World Federations of Neurosurgical Societies. He also considered the number one neurosurgeon in the skull-based surgeries around the Arab world and the Middle East. Hi, dearest Professor, can you hear me?
Hello, yes, thank you. Should I start sharing my screen?
Can go ahead.
Perfect. Okay.
Thank you very much indeed. Can you hear me? Can you see my slides?
Yes, perfect.
Super. First of all, I'd like to thank you for your kind invitation. And most importantly, I have to thank Professor Abida Shah for allowing me to start ahead of her, because I have to go to theater in a short while. So thank you, Abida, for giving me this opportunity. I'm going to speak tonight about the tuberculum silli meningioma, which is part of what is called as supracellular meningiomas. So supracellular meningiomas constitute 9% of all intracranial meningiomas, are made of three: planum sphenoidale, tuberculum silli, and diaphragma silli. So this is planum sphenoidale because the origin of the tumor, the epicenter is here from the planum, and the tuberculum is starting here in the tuberculum epicenter, and the diaphragma silli is actually coming from the diaphragma silli here. So the three of these constitute the supracellular meningiomas. Again, this illustration shows that the olfactory groove meningioma can extend backwards, but once you reach here to C, this is the planum sphenoidale, D is the tuberculum silli meningioma, and then the tumors arising from the diaphragma silli are called diaphragma silli meningioma. Tumors arising from the dorsum silli are dorsum silli meningioma. These are distinct, different types of meningiomas. So this is olfactory groove meningioma. Epicenter is here in the olfactory groove. This is not a supracellular meningioma, though it may extend backwards like this to this region, but one cannot include olfactory groove meningiomas in the heading of supracellular meningiomas. Again, extension from anterior clinoid process to the supracellular region, like in here, these are all my cases of anterior clinoid. These are not considered as supracellular meningioma because sphenocavernosous meningiomas are different, distinct entity. Again, those extending to the suprasellar area from the anterior clinoid. Again, these are my cases. Extending to the suprasellar does not make it a suprasellar tumor. So this is anterior clinoid meningioma. Dorsum cellular meningioma is different, distinct variety of these meningiomas. So I'm gonna confine myself to speak about tuberculum cellular meningioma tonight. So this is the illustration. This is a CT scan of this area. You can see here the sphenoid sinus, and this is the tuberculum cellular, and this is the olfactory tract sulcus. So tumor arising from here, and it then extend everywhere. In this paper by Lillian Shaker from Seattle, published in the World of Neurosurgery 2015. This is the picture from his paper to show the extension of these tumors. So he classified them into class 1. Size is less than 2 centimeters, but there is no extension and no obliteration or going into the optic nerve or vessels encasement. So class number 1, small size, no optic or vessel encasement. Class 2, 2 to 4 centimeters, there is some optic and vessel encasement. And the most difficult is a class 3, where there is involvement of optic vessels and sinuses, and the size is large. So this is the most difficult class of these tuberculum cellular meningioma. Like this illustration showing this tumor encasing the vessels, the nerves going everywhere. So one of the most important involvement is the involvement of the optic canal, because if the tumor starts in the middle, it can go to the right, it can go to the left, and involve both optic nerves. So this is the meningioma, and it will push the optic chiasma nerves backwards and up. And this is illustration from one of my cases showing the optic nerve here, and this is the tumor. These are the olfactory tracts which we preserved during surgery. So one can see actually pre-operative that the optic canals are involved. Like in this case, you can see the involvement. Or this case, you can see the involvement of the optic canals. Or this case. Or this case. And if you look here at the normal optic nerves with the subarachnoid space around them, this is obliteration of this variety because there is optic nerve involvement in this particular patient. Some of the illustrations of the optic canal involvement by the tumor. This. Hussam al-Mufti, 2010, described the optic canal involvement in tuberculum cellular meningioma, and he actually argued about the difference between microsurgery and endoscopic surgery for this kind of tumors, claiming that microsurgery is the only way to actually go around the optic nerve 360 degrees, while the endoscopy cannot do that. And I believe in this concept. Said in his paper, 2009, found that 23 out of 29 patients had involvement of the optic canal. So optic canal involvement is almost there in every case. So what are the structures that are related to the growth of this tumor? And this is optic nerve. Optic nerve here, we have to observe the falciform ligament because sometimes you have to open it because of the pressure on the optic nerves, like this. You will come across the pituitary gland and the stalk. You have to preserve them. Again, nerve chiasm and the stalk. So the tumor is here. You will come across these structures and you have to preserve them, like this. So this is the stalk, and this is the nerve, and this is the gland. Carotid artery will be always encountered. This is from illustration of this carotid artery from Vinko Dalan's book. So the carotid artery, as it comes into subarachnoid space, and this is the cave here, since it's ophthalmic artery from the dorsal aspect of the carotid underneath the optic nerve to go into the canal. Again, you will face these structures, so you better have a very good anatomical study of these structures. They are in danger when you are doing microsurgery for this kind of tumors. Again, you will come across the posterior communicating, you will come across third nerve and the area of the cavernous sinus too. If you are using the pterional approach, this is what we are going to see, pteroclinoid A1 and M1, and you will see the basilar tip here, third nerve in its segments. Again, the carotid artery is there in front of you, whether you're doing microsurgery or doing endoscopic surgery. Ophthalmic artery is in grave danger here. So as I said, it comes off the dorsal aspect of the carotid, goes underneath the optic nerve into the canal. It's always in danger here because the tumor is actually arising from here. So this is the clinoid segment of the carotid covered by the distal and proximal ring of the carotid. This is distal ring. So the carotid artery gives its ophthalmic branch. So this is the carotid cave in the medial aspect of the carotid on the left side, and this is the optic nerve. We have to remember that there are different origins and different ways of anatomy for this ophthalmic artery. It can go actually underneath the ring or above it, or actually it does not go at all there and it goes away from it to go into the orbit. So you have to remember the variations of the ophthalmic artery. I always say that one has to do MRI, MRA, MRV for every case. You cannot just do MRI because you need to see the variations of the artery and the variations of the veins, which are tremendous. Anterior communicating artery complex, and I always put this picture from Yazergil. It's in the hard disk of my mind, always this picture, beautiful picture by Yazergil to see the anterior communicating complex. So if you are operating here, like in the interhemispheric approach, optic nerve, nerve chiasm, and you can see the ACOM complex here, A1, A2, and their branches. Again, remember that so many variations of the complex there. You can have the fenestration of the artery, the communicating artery, and also the variations in the origin of Hubner's artery. This is the classical site of
حرم زمان قبل تقريبا 3-4 سنة. ايوه.
Can somebody manage it, control the voice, please? So this is the common origin of the recurrent artery of Hubner. It can come from A1, A2, or the junction. Again, the origin of the recurrent artery of Hubner is so variable. So you need to know it before surgery by doing either CT angiography or MRA or even conventional angiography. Again, they can be different. This side is different from this side. There could be duplication of the recurrent artery of Hubner. And again, this from the Yazergil book, the different origins of the recurrent artery of Hubner. They are different on different sides. Here, different from here, different from here, different from here. So that's why it is a must that you do proper angiography, be it conventional DSA, CT angiography, conventional, but you have to have proper study of the arteries there. Again, the hypothalamic perforators from the ACOM are so variable. The variations in the change of the direction of the ACOM is very important. Like when you are doing a clipping of the aneurysm, here you have the distal accessory artery, and here the azygos artery, and there's a difference between right and left arteries. Anterior clinoid process, you have to study it well. A beautiful paper, I ask you to read it. It's by Michael Lawton and Cavallero from Italy about the anatomical variations in the anterior clinoid. There are no two clinoids that are dissimilar. This study was on 597 skull base cadavers, and they study the various anatomy of the anterior clinoid. The clinoidal process of the carotid artery. And this study also showed the various anatomy of the clinoid. People think of the clinoid as a tiny structure. It is not. It has a tip, it has a head, it has a body and a tail. So it's a large structure that you need to deal with. Liliquist membrane is another structure that you will come across. It's made of two leaves, the diencephalic leaf and mesencephalic leaf. So this is the diencephalon, this is the mesencephalon, two leaves of liliquist membrane. So this is the liliquist membrane, and after removal, so this is the diencephalon, this is mesencephalon leaflet of liliquist. And this is how it looks on the MRI. You can see the both leaflets. So the management here is the first line is surgery. First line, second line, third line is microsurgery. The best chance for the patient for being cured. This paper by my friend Jose Landeiro from Brazil, and you can see this beautiful paper about the excision. Late Fred Gentili from Canada also published this paper about interhemispheric approach frontobasal for meningiomas. And this paper from my friend Kenji Ohata from Japan, showing also the bilateral subfrontal interhemispheric approach, and that if you go through the sinus, you can put a fatty graft to prevent CSF leak. This paper by Michael McDermott from San Francisco, showing the use of ICG to see the blood vessels of this tumor. I've come across bad surgeries, and I have to show you this to you. This is from another country outside Jordan. This is the pictures before surgery, and look at this. They just went inside the tumor, removing it from inside, and they just sent it for gamma knife. Again, I am against the abuse of gamma knife in the whole world. It's been abused totally. People don't do proper surgery, they do partial excision and they send for radiotherapy. This is not on. This is a crime against humanity, or doing any justice for the patient like this. Another patient who had this tumor, and again, they have just removed this part, which is the easy part, damaged the frontal lobe, but the tumor is still there. Again, this was done abroad. It came to Jordan. Another case from abroad, this tumor, which was very partially removed, and the patient was instructed, don't ever accept surgery because it will damage you. But they came to us and we removed the tumor. This is not good surgery, absolutely not. Endoscopy is another mode of treatment, gaining popularity, and this beautiful views that one can see during endoscopy made this very popular. It's good for a small tuberculum cell localized to the midline. It's invading the optic canals. That's not good. Whatever these papers say about 360 degrees of the optic canal cannot, I repeat, cannot be done through endoscopy. Also, the pictures via endoscopy, the distal and proximal, the carotid rings, and the opening of the dura and reaching to the tumor. This paper by Theodore Schwartz about the transplanum transperculum approach for supracellular tumors. Theodore Schwartz is one of the leaders in endoscopy. And this paper from Mark Rosen from the States about the use of endoscopy for excision of these tumors. Another paper by Theodore Schwartz and his colleagues, Vijay Anand and the others, showing the endoscopy approach. Theodore Schwartz again showing the approach. Paul Gardner as another endoscopist showing the use of endoscopy for this kind of tumors. Ricardo Caru, also from France, is another leader of endoscopy. Again, this paper from Canada, but this is reporting complication of endoscopy causing bilateral infarcts. Now I'm gonna give you an overview of my personal series between 1990 and December 2021. I did not include the last a year and a half, because you need a long follow-up before you include them, I have 68 tuberculum celli and 4 diaphragma celli. Females are more, of course. The average is 51 in females, 43 in males. And these are the cases of tuberculum celli meningiomas in my series, each and every one of them. 17 cases of those were very large. They were larger than 3 centimeters, so you can call them giant, some of them. So not only the location is difficult, but the size makes them more difficult, and the vessels encasement makes them terribly difficult. Again, I'm just putting pictures from my series. Jordan is a medical surgical hub in the Middle East, so we get lots of patients from the Arab countries around us. The value of CT in these cases is very important. It will tell you about the anterior clinoid, which most of the time you need to drill. So this is optic canal here, which is within normal, but here it is very narrowed, and you have to drill this kind of anterior clinoid here. This is aerated anterior clinoid. So you have to be aware that if you drill it, you may get CSF. And there are so many variations of the anterior clinoid aeration. So it could be aerated through the base of the anterior clinoid, like here. It's totally aerated or partially aerated. And this CT scan picture, you can see the tumor invading the sphenoid sinus. It's going inside. If it is going inside, you have to take it from there and you have to repair the sinus. Again, primary sphenoidal here is involved, so the value of CT is tremendous. It shows you the kind of variations of the bone involvement in the skull base. Again, MRI will show you the configurations and the vascular relationship. So you can see actually both tools are inside the tumor. This is a ACOM inside the volume of the tumor. And this one and this one. So when you see a picture like this, you may say this is inoperable. Don't make this decision. You only make this decision of being operable or not operable only inside the surgery. I tell you, in these cases, all of them were operable and I could remove them. So they look kind of difficult, but once you go in and define the plane of the cleavage, you can succeed. MRA or CT angio or whatever is important to see the variations. And here we have hypoplastic A1. MRV will show you the venous relations. The differential diagnosis of these tuberculum celli meningioma is very important. The first to think of is pituitary adenomas, and I've seen so many cases of tuberculum celli being operated transnasally on the assumption that they were pituitary adenomas, destroying the pituitary and the way and causing major difficulties, major complications. So this is from Johns Hopkins. This is a very serious paper. Johns Hopkins, 2017. They reported 57 patients of supracellular meningiomas. 1/3 of them were diagnosed as, not meningioma, as pituitary adenoma. So in a country like United States, from Johns Hopkins, people still finding a difficulty to recognize and differentiate between tuberculum celli and pituitary adenoma. So this is the meningioma and this is the adenoma. They are different and the features are different. The nodularity goes more with the meningioma. The epicenter, you have to be careful. So you would look at the epicenter and you can see there is a plane of cleavage. This is the pituitary and this is the tuberculum celli. Pituitary and supracellular tumor. So you can see a plane of cleavage. And the epicenter of the tumor is here from the tuberculum celli, not from the pituitary. So again, looking at those meningiomas, you can tell they are meningiomas. Pituitary adenoma is totally different. The epicenter is from here. As I said, nodularity goes more with meningiomas. So one should not fall into the fault of not differentiating adenoma from tuberculum cell meningioma. Nodularity is in favor of meningioma. Cranopharyngioma is another lesion in that area that can be mistaken, like in these cases in my series, germinomas in the supracellular area and in the pineal area. If you don't have it in the pineal area, it is just in the supracellular area, then germinomas can be mistaken for the others. Other lesion that are found necessary to differentiate is the supracellular epidermoid tumor. In this case, it was totally against the normal rules of images of the epidermoid. Totally unusual. Again, excised successfully, and it was an epidermoid tumor. Teratoma, this Bahraini girl, histiocytosis, optic nerve glioma, sarcoma, lymphoma, chordomas can mimic the tuberculum cell meningioma, plasmacytoma, sinonasal carcinoma, metastasis in that area, sarcoidosis, aneurysm. All of these should be in our mind when we consider the differential diagnosis of these cases. In my series, 55 cases presented with visual deterioration, which is expected. But other presentation were there: epilepsy, headache, memory changes, endocrine changes, anosmia, Foster Kennedy, long tract signs. But the commonest presentation is visual. And we do full visual assessment for each patient: visual acuity, visual fields, fundoscopy, and optic OCT. Each and every patient would receive Karnofsky Performance Scale assessment. In my series, visual acuity was decreased in one eye only, in 22, both eyes in the majority, 36. Again, that speaks very much of the tumor going into the optic canals. Visual fields, not only by temporal hemanopia, it can be any visual field defect depending on whether you are in the center, going to the right more, or to the left more. My surgical approaches in my series, I use the interhemispheric transbasal in majority, 52, and I use the unilateral terional in 12 and lateral subfrontal in 4. I did do optic canal deroofing and anterior clinoidectomy in 42 patients, and I released the falciform ligaments in 3. So this is the interhemispheric transbasal approach. I preserved the periosteum. I cut the superior sagittal sinus in the most anterior part of it. I preserved the olfactory tracts. I put a piece of sponge here to prevent the olfactory tracts from avulsion from the cribriform plate. And this is the preservation of the olfactory tract. And this is the tumor. And then you start drilling of the anterior clinoid. Here you remove the last piece of the anterior clinoid. You open the falciform ligament and you open the optic canal, the bony optic canal. If the tumor is invading the planum sphenoidale, you open it and you go into the sphenoid sinus. This is right side, this is left side, this is planum sphenoidale here invaded by the tumor. So you are here looking at the inside of the sphenoid sinus. There's still a tumor here, you can also drill both optic canals. That's why I go interhemispheric. And once you go into the sphenoid sinus, you have to repair it by fat and grafts and so on. And I'm always drilling the anterior clinoid to open the optic canal and look at the ophthalmic artery. So this is the case that I showed you going into the sphenoid sinus and its repair. And when you do it properly, you will see that you have preserved the stalk going into the gland, and you can see through the varicose membrane the basilar artery, cerebrocerebellar artery, and posterior cerebral artery, and the third nerve going into the roof of the cavernous sinus. Beautiful view after excision of that tumor. So this is the basilar artery, cerebrocerebellar, posterior cerebral, and you can see the third nerve coming off the midbrain between the two arteries. Follow-up in my cases was very long. I do not include any case less than 24 months, have achieved gross total resection in the majority, 66, and recurrence in 1. Subtotal resection was done in 5 and have recurrence in 4. So you always go for gross total resection. You take the tumor, you take the dura, you drill the bone, you do everything possible. Because even if you have a grade 1 meningioma benign, Simpson grade 1, still you have chance of recurrence 5 to 9%. I've lost one patient because of carotid injury. Morbidity in my cases, smell was affected in 7 cases. So although we preserved the olfactory tract, smell was lost in 7 patients. Vision deteriorated in 2 patients. There's sometimes developed temporary DI, wound infection, CSF leak, and so on. These are the morbidity. As for the visual outcome, improved in 49 cases, got worse in 2. One was early and one was late. This is just to show you the visual improvement. This is the visual fields before. Left, very much affected. Right was 0. And this is the visual fields after the surgery. So this is pre-op. Nothing here. And then it opened up post-op. So we do visual field before and after surgery, in addition to Karnofsky performance scale before and after. So this is a very beautiful view of one of my cases. This is the optic nerve on the left. And you can see the carotid artery, and this is the anterior cerebral. Because the tumor was sitting here pressing, so the anterior cerebral actually pressed on the junction of the optic nerve and causing this groove, which was pale looking. So continued pressure on the nerve can cause ischemia. Show you some of my cases and then I'll wrap up. Cases before and after. Before and after, preserving the stroke and the pituitary. Again, this case with the pre-operative, and this is post-operative in this lady, Jordanian lady. Again, here you can see the aeration of the anterior clinoid process. This is the post-op. And we do the post-operative MRI the very following day. We don't wait on it. We don't do CT scans afterwards. The claim that CT is superior to the MRI in showing hematoma is nonsense. MRI is superior to the CT scan in showing the acute, subacute, and chronic blood. This lady also came from Libya with this tumor. She almost lost her vision. And, you could save her. And she was actually pregnant, and you can see the hypertrophy of the stroke. We delivered her by cesarean, and then we went into the tumor and took it out. So here she is. Another case of this supracellular tuberculum cell meningioma, and this lady who is actually a United States citizen here in Jordan. She trusted us to do her surgery. This is pre and this is post-op. And I followed her for so many years, I think about 12 or 13 years without any recurrence. Supracellular tuberculum cell meningioma before and after. So it's not a case, it is not the occasional case, it's a school of thought. You are going for radical excision to give the patient the best chance first time during surgery. There's no nonsense of doing partial excision and sending for radiotherapy. Radiotherapy, radiation in general, is harmful to the patient. You should only use it if it is absolutely necessary. There is abuse of radiosurgery in the whole world, especially in the Middle East. This is what it looks like. In inoperable case, we could actually remove it totally and completely. This very large tumor going into the sphenoid sinus, tumors going into the sphenoid sinus. We actually drilled and went into the sinus and repaired it. And this is also, this lady came up to us from Saudi Arabia. Again, this patient with this tumor. Again, I'm showing you these to show you that it is not a case. It's not 2 cases. It is a school of thought. Before and after surgery, this lady came from Palestine, from the West Bank of Jordan, occupied Palestine, and she had the best of results. this patient who is only, he's blind in one eye. He lost it during an injury in his childhood. So this was a challenge to try to preserve the vision in the other eye. And this is the tumor. And post-surgery, we achieved a good result of excision, but he developed some CSF leak because I was overzealous in doing the drilling of the part of the roof of the orbit near the optic canal. So I went into the ethmoid sinus. He came with meningitis and free air inside, and we could repair it, and he did well. This is the end result. So many cases that we really helped by doing proper surgery. And this lady from Philippines who's residing in Jordan also had the best of surgery. I'm going to show you some of these clips of surgery. I am going to go quickly at them. This is a terional approach. I'm drilling the sphenoid wing. I'm opening the dura, opening the Serbian fissure, opening of the arachnoid around the optic nerve, and trying to devascularize the tumor from the tuberculum celli and the planus sphenoidale, using the ultrasonic aspirator to debulk the tumor from inside, and then take the arachnoid away from the tumor towards the optic nerve. This is the rule of doing surgery in that area. Preserve the blood supply of the optic nerve and continue debulking and dissecting the tumor completely. So removing it here seems to be complete. I don't stop there. I actually go and remove this involved dura to prevent any recurrence and preserve the optic stalk. So this is the final appearance. The optic nerve on the right, on the left chiasm, and the dura that we removed from the tuberculum cell area. Again, here showing this is the case where it was involvement of the sphenoid sinus. I'm using the drill here to, this is the left optic nerve. So I'm drilling the clinoid process here, but there is a tumor also medial to it. And I will do that again to see the ophthalmic artery. So you can see, I can see here the ophthalmic artery coming off the dorsum aspect of the carotid going into the canal. There was a tumor inside the optic canal. So if I didn't do drilling and look for the ophthalmic artery, then there will be recurrence. Going to the other optic nerve, medial to it, again drill it, and drill the planum. Tumor is going into the sphenoid sinus, I follow it. So one has to be aggressive with this tumor if one wants to prevent recurrence. So removing it completely, remove every bit of the tumor there is. This is the interhemispheric approach, preservation of the olfactory tracts. You can see I'm separating the tumor from A1. This is A2, and ACOM is here. So it looked inoperable on the images before surgery, but going slowly, you could find the plane of cleavage and separate the tumor from the ACOM and the hypothalamic branches. So once you find the plane of cleavage, you just proceed. If the tumor was involved in the wall of the vessel, I would have stopped. But don't just make the impression or have the impression of this is inoperable from just looking at the preoperative images, because that is not on. You decide when you go in. You are going in with the idea that I'm going to have full gross total resection, removal of the dura, removal of the involved bone, and so on and so forth. So we'll continue. Again, you can see how the chiasm is being pushed. Here, separating the arachnoid, olfactory tract, olfactory tract. It's important to preserve olfaction for these patients, and 70–80% of them preserve the olfaction by doing so. So this is the origin of the tumor. I removed the dura. You can see the stalk here, nerve chiasm. So here, some tumor going into the optic canal. I have to remove it. And then I also excise the dura like this, because this is the cause of recurrence. I don't leave that. I have to remove it. This is the 3D. I always record my surgeries as a 3D and 2D. So if there is the chance of using the 3D, I will use it. This is the cutting of the most anterior part of the superior sinus, going interhemispheric, subfrontal, interhemispheric, as you can see. Effective tract on the right and the left. This is the tumor. Interhemispheric preservation of every structure there is. You can see the A1, A2, ACOM are inside the tumor. Again, by perseverance, by being careful, by knowing the anatomy, you can preserve these structures. It looks haunting, it looks formidable, but slowly, you'll find the plane of cleavage, and you can preserve every little branch of any artery. Movement of the origin here, using the ultrasonic aspirator again. You can see the arteries inside the tumor. Sharp dissection is useful. Taking the arachnoid with the arteries away from the tumor towards the neurovascular structures to preserve blood supply. Again, here it seems to be impossible. It was possible actually to remove it completely. Debulking, dissection, until you achieve complete tumor resection. Because this is your aim, radical excision with no mortality and no morbidity, if you can. Again, you can separate the tumor from the echo complex. Look at this here. Tumor seems to be stuck to the arteries, but careful dissection will preserve them. So this is the final picture. Every important structure has been preserved, including the stalk, both sides, right and left, and all the structures that you need. I'm going to stop here. I think there's one surgery here. Let's let me look. Yeah, I think we'll stop that because it's just the same principle. I'm coming to my conclusions, and thank you for being patient with me. My conclusions are that the transbasal interhemispheric approach is an excellent approach because it can attack the tumor in the middle. It can go to the right optic canal, left optic canal. You can go into the posterior fossa, look at the tumor going there. You can go backwards into ACOM between the two hemispheres. So it's a very good approach that I use often. And to preserve the visual vision, the visual outcome depends on your expertise and on your expert knowledge of the anatomy. I thank you for your patience, and if you have any questions, I'm happy to take it.
Okay, Ahmed?
I thank you, Professor. It's really an amazing presentation. So if there is any question, you can put it for the professor.
Thank you for your patience, and if you have any questions.
I thank you, Professor. It's really an amazing presentation.
Are there any questions?
Professor, I have a question for the professor. First of all, congratulations for your excellent lecture, amazing surgical technique. And I was wondering, in all or maybe most of the videos, I saw that you drill the intradurally the anterior clinical process. When would you do, for example, an extradural training? Something like you prefer, some indications.
I do drill the anterior clinoid extradurally as I'm drilling the greater wing of sphenoid, and the last space I drill it intradurally. So I do it both sides, extra and intradural.
The anterior clinical process. When would you do, for example, an extradural training? Thank you.
I hope that you would excuse me because I have to go to theater now. Again, thank you, Abida Shah, for giving me the chance to speak ahead of you. You have my full respect, and I hope you can my regards to you and to Atal Guru. Thank you very much indeed, all of you.
Thank you, Amen.
Thank you, Dr. Salim.
Thank you so much. Hello, everyone. So good afternoon and good evening to different people around the world. I want to introduce Carolina Fernandez. She is the president of Walter Dandy Neurosurgical Club in Portugal. Unfortunately, she couldn't attend this session. Her club is part of the Walter Dandy Neurosurgical Society. There are 56 clubs around the world, and the aim of their club is to join medical students with interest in neurosurgery and neuroscience, and the sharing knowledge and organize webinar and scientific activities. And now I want to introduce the next speaker, Dr. Kabaya Shahed. I'm sorry if I'm not pronouncing it correctly, but we will be happy to hear after that. He will speak about anatomy of the skull base. He made a fellowship in endovascular surgery in Mayo Clinic. He was assistant professor in neurosurgery, GS Medical College. And he was a member of Skull Base Surgery Society of India. So welcome, and we're happy to continue this session. He will speak about anatomy of the skull base.
Thank you, Dr. Moore. And I'll just share my screen. John, there is some disturbance.
Yes, okay, let me get that, okay. I love it when you boss me around.
Okay, it's gone. It's gone.
Okay, thank you.
Okay, thank you, John. Thank you, Dandy Society, for this invitation. And you have given me quite a vast topic of anatomy of the skull base. It's too difficult to cover the whole thing. So I'll just go and cover bits of the important parts. So this is the view from the inside of the skull base, which we divide into the anterior, middle, and posterior cranial fossa. So basically, when you are studying the bony anatomy, you have to remember that there is a midline part and there is a lateral part, and they all come together at these fissures, or, where they join to each other. So on the anterior side, you have the ethmoid bones in the center and the frontal bones at the side. In the middle cranial fossa, basically you have the sphenoid bone in the center and the temporal bones at the side. And posteriorly, you have the clivus in the center and the occipital bones in the side. So all these structures together forms the bony anatomy of the skull base. And here you can see them more clearly. Here the anterior part of the skull base has been removed, but you can see this midline bone, that is the sphenoid, and this part, that is the clivus. And this is the temporal portion of the bones, and this is the occipital portion. And you can see how they come together at all these sutures and at these fissures and come together to form the skull base. Now let's start with the anterior cranial fossa. So the anterior cranial fossa has at its center the ethmoid bone, and more posteriorly the sphenoid, and laterally the frontal bones, and where they come across to meet the lesser wing of the sphenoid. So in the center, you have the cribriform plate and the crista galli. So you see these multiple holes in the cribriform plate, which allows the olfactory filaments to pass on from the nasal cavity into the skull, into the cranial cavity. It also transmits the anterior and the posterior ethmoidal arteries. Coming further down, so you see this is the cribriform plate and the crista galli. Sometimes there's an attachment of the sagittal sinus that comes all the way down to the anterior cranial fossa. So coming now here posteriorly, as you have seen some of these images. So this part is the planum sphenoidal. This is the tuberculum sellae, and this is the dorsum sellae. The sulcus between the planum and the tuberculum is the chiasmatic sulcus. And here, this is the optic canal. Now, this important structure that you see here is the anterior clinoid process. And a lot of dissections are just focused on how to drill the anterior clinoid process and how to get access into the middle part of the skull base or to the clinoidal part of the carotid artery. So what is this anterior clinoid process? So you see this triangular shaped bone, which has a base that joins with the lesser wing of the sphenoid. And it has two roots, the anterior root and the posterior root. So the anterior root forms the roof of the optic canal, as you can see here. And the posterior root is on the floor of the optic canal. And this part is actually known as the optic strut. So this is the bone that all of us have to realize that this is what is the optic strut. And then this is the lesser wing of the sphenoid and the greater wing of the sphenoid. And they come together here at the superior orbital fissure. And basically, and then the midline here is the sphenoid bone. So these are the basic constituents of the anterior cranial base. Some other important dural relation is you have this relation here. You see this ligament that is going over the optic nerve and right up to the middle part of the skull base, joining the dura here. This is the falciform ligament. There are other relations of the anterior clinoid process that we will cover in the middle cranial fossa base. So basically, we have seen the basic bony anatomy of the anterior cranial fossa. Now, to study the anatomy of the interior part of the anterior cranial fossa, let's study it with some approaches. So there are three basic approaches to the anterior cranial fossa: the pterional approach, the subfrontal approach, and then the bifrontal approach. And of course, there are midline approaches when you can come from the nose. So the selection of approach for an anterior cranial fossa tumor basically depends on its location. The more lateral the tumor, you'd prefer a pterional craniotomy, whereas the more midline the tumor, you'd prefer a subfrontal approach. And sometimes for large tumors that extend downwards, you can take a bifrontal approach. For purely midline tumors, you can take a transsphenoidal or a transnasal approach. So this is just a basic few steps of the pterional craniotomy, as I have presented in an earlier presentation. And you can reflect the temporal fascia and muscle in many ways. You have the interfacial and the subfacial techniques to preserve the branches of the facial nerve. And then you can take the muscle down, you can reflect it anteriorly or you can reflect it posteriorly, and you get this exposure of the bone. You make the key burr hole in this region, and then you fashion the craniotomy around it, and you open the dura, and this is the exposure that you will get. Now, this is the anatomy of the anterior cranial base that you have to understand. So this is the frontal lobe, the temporal lobe. This is the region of the insula, and these are the branches of the middle cerebral artery as they are coming out from the Lyman insulae on the surface of the insula. Going in the depth, so let's go step by step. So when you open the dura, one of the first things that you will see is these sylvian veins, and you have to learn how to dissect around the sylvian veins so that you can enter into the sylvian cistern. Generally, there is a good opening here, the region that is known as the anterior sylvian point. It is in the region of the pars triangularis here, and there is a dilatation of the sylvian fissure in this region where you can open the arachnoid and enter into the sylvian fissure. So you either dissect on the frontal or the temporal side and split and reflect the veins and go in, and this is what you'll see. So you'll see the middle cerebral artery coming up with its bifurcation and then going up into the insula. More beneath downwards, you will start seeing, so in the proximal part of the sylvian cistern, you will enter the carotid cistern. So the proximal part of the sylvian cistern joins the carotid cistern, and you see the carotid artery coming out and bifurcating into the anterior cerebral and the middle cerebral arteries. Here you can see it more clearly. So these are the veins. This is the sylvian fissure. This is the frontal lobe that is retracted. These are the olfactory nerves. This is the dural reflection. This is where the optic nerve is entering into the optic canal. And here you see the carotid artery, which is bifurcating into the anterior cerebral artery and the middle cerebral artery, and then the middle cerebral artery going on forward into the Sylvian fissure with its bifurcation. Here downwards, you see the third nerve. So this is the basic exposure that you will achieve with a pterional craniotomy. And for tumors in this region, this approach is a good workhorse and gives you a great exposure. You can get an exposure all the way right from the carotid cistern, all the way behind to the interpeduncular cistern, to the basilar artery and to the brainstem using this pterional approach. So here you see in this specimen that the veins have been reflected here. And here you can see the carotid artery and this whole complex of the middle cerebral arteries in the Sylvian fissure. So this is how the Sylvian fissure opens into the, this is the proximal part of the Sylvian cistern, where the middle cerebral artery is going on to become its bifurcation. And this is the carotid cistern, where you see the carotid artery bifurcating into the anterior cerebral artery and the middle cerebral artery. And this is the opticocarotid recess between the optic nerve and the carotid artery. And it forms a good entry point for approaching tumors in this region. Now that is the basic of a pterional approach. Now what happens when the tumor is more towards the midline? So if your tumor is in the center of the skull base, sometimes the pterional approach will not give you access to this side. If it is a unilateral tumor, you can still maybe get access through a pterional approach. But if it is crossing the midline, a pterional approach becomes a little difficult and cumbersome. So then you have the subfrontal approach, which gives you a beautiful access to both the ipsilateral and the contralateral side, and you can approach midline tumors using this. So basically a pterional craniotomy we use for aneurysms and for laterally based tumors, and a subfrontal approach for more medially based tumors. So this is the little difference in anatomy that you will see when you're coming by using a subfrontal approach. So this is the frontal lobe that is retracted. Now you see the optic nerves, the ipsilateral, the contralateral. Here you see the carotid artery, and this is the anterior cerebral artery on one side, the anterior cerebral artery on the other side, and this is the ACOM artery that is connecting the two. So here you see this is the carotid cistern and this is the chiasmatic cistern. A closer view, and you see this structure here, that is the pituitary stalk. This is the diencephalic leaf of the liliquous membrane. If you open it, you will be able to enter into the interpeduncular cistern. This, of course, is the carotid cistern, and you see the ICA bifurcating into the A1 here, and the middle cerebral artery laterally, and here this is the ACOM. So this is the carotid cistern, and this is the chiasmatic cistern. This is the lamina terminalis cistern. So this membrane that you see here is the lamina terminalis, and when you open it, you will enter into the third ventricle. So basically the lamina terminalis is actually not a telencephalic structure. It is a diencephalic structure. It forms the anterior wall of the third ventricle, and it's part of the diencephalon. It's just an interesting fact. So here you have three cisterns that are coming together: the carotid cistern, the lamina terminalis cistern, and the chiasmatic cistern. And once you open the liliquous membrane, you will enter into the interpeduncular cistern. So that is what we have done here. So now you see the optic nerve is deflected here, and you see these arachnoid trabeculations. So this is the opticocarotid space, and you see this arachnoid trabeculations of the liliquous membrane. And once you open that, you'll be in the interpeduncular cistern. So this is the brainstem, this is the basilar artery, and this is the third nerve. This is the posterior clinoid process. And here you can see the structures labeled. So here you have the anterior clinoid process, the third nerve, the optic nerve, and the posterior clinoid process, the basilar artery, and this is the posterior part. Here you can see is the brainstem. And of course, the ICA with the bifurcation into the middle and the anterior cerebral artery. This is a close-up view showing the structures. Again, the third nerve and the basilar artery with its bifurcation, and this is the brainstem. So this is the anatomy of the subfrontal approach. So a tumor in this region, for example, a suprasellar meningioma, or an olfactory groove meningioma, can be easily approached with this unilateral subfrontal approach. And that is basically what we use for approaching these kind of tumors. And this is what the exposure provides. So here you can see laterally, you can enter into the Sylvian cistern. Here you can enter the carotid cistern, the chiasmatic cistern, and the lamina terminalis cistern, and then debulk the tumor and protect all the neurovascular structures. So this is Professor Goel's paper on the subject of tuberculum cellae meningioma, and this is what we use, a unilateral subfrontal approach. So this is the tumor that you see, and we've approached it from a unilateral approach subfrontally and excise the tumor. Let me just show you some bits of the video. So you see, this is the craniotomy. And the first step essentially is going laterally and opening the Sylvian cistern so that you can release the CSF. There you can see that the CSF is released and the brain immediately becomes lax. Then coming to the midline towards the tumor. So you start debulking the tumor from the base, you devascularize it by disconnecting it from the base. And then you start dissecting around the tumor, you start identifying. You see how closely related the optic nerve is to this tumor. This patient had a bad visual problem on that side, but now you can see the dissection and removing the tumor from the inferior aspect of the optic nerve. It's a firm tumor, and sometimes some sharp dissection has to be done so the tumor can be resected. And this is all possible from a unilateral subfrontal approach. Here you can see how closely it is stuck to the optic nerve, and that explains the bad vision in this patient. And quite a firm tumor, so difficult to remove, difficult to remove with a suction. And here posteriorly, you will see the anterior cerebral artery. And now the tumor is being dissected from the anterior cerebral artery. And now from the optic nerve, so very, very densely stuck to the optic nerve in this region, as you can see. And this is at the end of the resection, where you can see all the structures. This is the pituitary stalk here in the midline. This is the tumor that has been dissected, except from that small part near the optic nerve, where it will be now cut and removed, preserving the optic nerve completely. So this is what we are able to do through a unilateral subfrontal approach, and this is the approach that we prefer. Now looking at the next approach, that is the bilateral frontal approach. So this is a huge approach. It is a cumbersome approach, but if you have to use it, you have to use it in some tumors, especially tumors that enter from the cranial cavity into the nasal cavity, or those that are coming from the nose inside, basically for olfactory esthesioneuroblastoma, because you need a real basal exposure. So that is how you can remove the bone and approach. So here you can see that that part of bone can be removed and you can enter into the nasal cavity and remove all the tumors. And sometimes, this approach is used for when people are doing the bifrontal approach to anterior interhemispheric to approach craniopharyngiomas. And this is, when you're using this approach, you must always remember that there is a beautiful flap of pericranium, and that is the extended subgaleal pericranial flap as described by Dr. Goel. And if you raise this flap, you have a very beautiful flap to repair the skull base. You do not need any artificial material. You can just drape the anterior skull base and exteriorize the frontal sinus, and it gives a very good cover to without using any artificial material. So this is the exposure that you obtain by this bilateral bifrontal approach. This is an anterior interhemispheric. You see the olfactory nerves, you see the optic nerve and the chiasm and the anterior cerebral artery and its complex, and this is the region of the corpus callosum. So initially, when we usually encounter a lot of huge olfactory groove meningiomas. So in the initial part of our experience, we used a bifrontal approach. But now, as we are becoming more familiar, most of these tumors we are approaching through a unilateral subfrontal approach. So this was one case that I had operated recently and done by unilateral subfrontal approach. And this is the post-operative scan. This is again another huge tumor that I had operated. Of course, I went unilateral subfrontal for this also. So basically, the unilateral subfrontal approach is quite a versatile approach, and we can easily approach tumors with this using this. Now let's go a little posteriorly to the region of the cavernous sinus. So now you can see this coronal image, and you can see that this is the temporal lobe, this is the dura of the cavernous sinus, this is the lateral wall of the cavernous sinus, and this is the cavernous sinus proper with the carotid artery and the venous plexus, and this is the region of the sphenoid and the pituitary. So let's study the anatomy of the cavernous sinus quickly, and then let's go to the posterior fossa. So some important points in the cavernous sinus and the middle fossa anatomy is for cavernous, to understand cavernous sinus, you have to understand dural relations. So basically what happens is on the floor of the middle cranial fossa, there is an endosteal layer of dura, and on the base of the temporal lobe, there is a meningeal layer. So where these two layers meet and split, that is where the cavernous sinus resides. And if you want to expose the cavernous sinus, the dural peeling is one of the most important things that gives you an access into the lateral part of the cavernous sinus. So this is a superior view where you see the dura of the middle cranial fossa. You saw this dura continues here medially, goes to the anterior cranial fossa to the diaphragm and forms the diaphragm ocelli. I will show you in another image. And these are some important nerves that enter. So this is the superior part of the cavernous sinus or the roof where the oculomotor nerve is entering. This is the lateral wall of the cavernous sinus where the trigeminal nerve is entering. And this is, of course, the sixth cranial nerve as it is entering the cavernous sinus. So this is a closer view. Now you see this dural relations. So this dura forms the lateral wall of the cavernous sinus, then goes above here. This is the falciform ligament, goes on to the tuberculum and planum, and then comes back posteriorly to form the diaphragm ocelli, and then again turns back here, forming the medial wall of the cavernous sinus here in this region, and then going back again to merge with the roof and the lateral wall of the cavernous sinus. So these are the dural relations of the cavernous sinus. And this is the oculomotor nerve, this is the carotid artery, this is the optic nerve, this is the pituitary gland and the pituitary stalk. This is the tentorial edge, and this is the fifth cranial nerve as it is entering the cavernous sinus. So for studying cavernous sinus, there are a lot of anatomy of triangles that are involved and that you have to understand. You cannot, these triangles are important because they allow you approaches into the cavernous sinus. So this is the superior view of the cavernous sinus where you see two important triangles here. So this is the clinoidal triangle. This is the oculomotor triangle. So basically the clinoidal triangle is here, and when you open this triangle, you will get access to the anterior clinoid process, and you will get access to the clinoidal part of the carotid artery. And this, if you see this is the oculomotor nerve, and it carries with it a sleeve of dura as it enters into the roof of the cavernous sinus, and it forms the oculomotor cave around the cavernous sinus. This has also been described by Dr. Goel, and this region is actually the origin of oculomotor nerve schwannomas. Just like in the Meckel's cave, you have trigeminal schwannomas arising from the oculomotor cavern, the oculomotor nerve schwannomas arise. So again, coming back here, so this is the roof of the cavernous sinus where we saw two triangles. Now in the roof, what two nerves enter? So the third cranial nerve and the fourth cranial nerve. So these are the two nerves that can be seen from the superior aspect. Here you again see the dural relation as the dura turns. And here you see that the medial wall of the cavernous sinus is quite dehiscent. So this gives an entry to tumors, especially pituitary tumors. They can enter from this medial wall because of these inherent deficiencies in the medial wall. And it is a very, not a very thoroughly understood subject, this medial wall of the cavernous sinus. This is the optic nerve and the ophthalmic artery as it is entering. And the dura in this part of the cavernous sinus has been removed. And you can see the basilar venous plexus in this region. Now, the roof of the cavernous sinus has been removed here. And now you see the whole third nerve as it is going on to enter into the superior orbital fissure. These are fibers of the fifth nerve. This is the fourth nerve as it is entering into the cavernous sinus in the roof of the cavernous sinus. If you see this, there are venous plexuses on the medial side. So this is the medial venous plexus of the cavernous sinus, and this is on the lateral side. So basically the cavernous sinus is a huge plexus of veins. Here you see this ligament. This is Gruber's ligament or the petrosphenoid ligament. And here you can see the sixth nerve that is entering here beneath the Gruber's ligament and entering into the cavernous sinus, where it will run lateral to the carotid artery. So there are two other important triangles here, the inferomedial triangle and the inferolateral triangle. So the inferolateral triangle gives exposure to the trigeminal nerve, and the inferomedial triangle is the one that you can reach by using the Kawase's approach. And the most important content in this triangle is the sixth cranial nerve and the petrosphenoid or the Gruber's ligament. So now having a closer view, here you can see the Gruber's ligament more clearly, the sixth cranial nerve, the third cranial nerve, the fourth cranial nerve. This is the tentorial edge. This is the fifth cranial nerve. And this region here is where the superior petrosal sinus will come here and joins the cavernous sinus by means of the superior petrosal vein. So this is the region of the superior petrosal sinus. Here is the basilar venous plexus. These are dorsal clival arteries, which are branches of the cavernous carotid. And I will show you later in the slides how they branch. So now we looked at the cavernous sinus from a superior perspective. Now let's look at it from the lateral perspective. So this is the first dural layer, that is the lateral wall of the cavernous sinus. And once you peel that, you will start seeing the nerves in the lateral wall of the cavernous sinus. So basically, it is the V1 and it is the V2. The V3 actually does not form part of the lateral wall of the cavernous sinus. It comes out and runs here into the foramen ovale, and it does not form an actual part of the cavernous sinus. So now the whole dural layer has been peeled off, and you see the fifth cranial nerve. This vessel here that you see here is the middle meningeal artery. And this is a very important vessel. It is entering through the foramen spinosum. Basically, when you want to approach the cavernous sinus, you have to cut this artery, coagulate and cut it, and that helps you in peeling the dura towards the lateral wall of the cavernous sinus. So here you see these structures. So this is the tentorial edge. This is the third cranial nerve. This is the fourth cranial nerve. This is the V1, the V2, and all these nerves here are entering the superior orbital fissure. The V2, the maxillary branch, is entering the foramen rotundum, and this is the mandibular, and it is going into the foramen ovale. This is the superior petrosal sinus, and it is communicating with the cavernous sinus, and this is the lateral venous plexus in the cavernous sinus, and this is the carotid artery. Now you can see here more clearly some structures. Just a closer view. Let's go into the next part. Now here, the fifth V1 division has been raised superiorly to see this nerve. So this is the sixth cranial nerve as it runs on the lateral aspect of the carotid artery. Once we remove this venous plexus, we will be able to see that artery. And here, this trigeminal, the gasserian ganglion has been pulled forward, and the trigeminal nerve has been pulled forward, and you see this bony impression on the petrous bone, and this is the trigeminal impression, and this is where the ganglion lies. Basically, this Meckel's cave and the lateral wall of the cavernous sinus, they have a common dural wall as it covers all this part. And here you see that this is the region of the superior petrosal sinus. Of course, the tentorial edge, the third cranial nerve, the fourth cranial nerve. This is the dorsal clival artery as it is going on to supply the clivus. Now, all the venous plexuses of the cavernous sinus has been removed, and now you see the carotid artery very clearly. Now, here you see that another important structure, the anterior clinoid process, has been removed. There are two important dural folds here. So this is the upper dural ring and the lower dural ring. And within it, between these two rings, is the clinoidal segment of the cavernous carotid artery. So when you want to approach this segment, you have to drill the anterior clinoid process, whether you drill it extradurally or whether you drill it intradurally. This is what you have to aim to achieve. There's also very frequently a venous plexus in this area, and that also bleeds when you're removing the ACP. And the other nerve that can be mostly injured when you're doing drilling of the ACP is the third cranial nerve. So see how close the third cranial nerve is to the anterior clinoid process, and it is prone to injury. So this is the third cranial nerve, the fourth cranial, and the V1 as they're entering the superior orbital fissure. This is the V2 and this is the V3. So you see how this ganglion, the gastrian ganglion, has multiple filaments that, kind of amalgamate with each other and form a kind of a plexus here. And this is the carotid artery. Let's look at the carotid artery a little later. Now, there are many important triangles here. So this is the supratrochlear triangle that is between the third and the fourth cranial nerve. This is the infratrochlear triangle, or the Parkinson's triangle, that is between the fourth cranial nerve and the V1. This is the anterior medial triangle between the V1 and the V2, the anterolateral triangle between the V2 and the V3. So all these triangles give access to different parts of the cavernous sinus, and that is very important. This one is Parkinson's triangle, is the one that it gives you an access to the posterior bend of the carotid artery. And actually, Parkinson believed that to be the origin of caroticocavernous fistula, and he used this approach to obliterate this fistula. And the other two triangles here are the posteromedial and the posteromedial and the posterolateral triangle. So here you see the middle meningeal artery, and this one here gives you access. This is the Kawasaki triangle and gives you access to the petrous apex when you're drilling in this area. Let's look at the carotid artery. So this is the ligament that connects here, and this is the petrous carotid comes out here and enters into the foramen lacerum. And this is the petrous carotid artery. This is the posterior bend or the posterior genu of the carotid artery. This is the horizontal segment, and then there is an anterior bend, and then an ascending anterior segment. So these are the parts of the cavernous carotid artery. Here you see the sixth cranial nerve as it is running closely in relation to the carotid artery. This is the meningohypophyseal trunk of the carotid artery, and it gives out various branches to various structures. Basically, it gives the inferior hypophyseal artery, it gives the tentorial artery, and it gives the dorsal clival artery, which we already saw earlier. And this is the region of the foramen lacerum as the carotid artery is entering from the petrous into the carotid, into the cavernous sinus. So this is again the posterior genu, the horizontal segment. And once you remove the anterior clinoid process, here you've removed the anterior clinoid process, and then you see the whole carotid artery. So it's the upper dural ring, the lower dural ring, and here you have the horizontal part, the anterior genu, and the ascending part of the carotid artery. This is the ophthalmic artery, and here these are the branches of the carotid. So this is the inferior hypophyseal trunk, inferior hypophyseal artery. This is the tentorial artery, and more posteriorly that you see these vessels are the dorsal clival branches, which go on to supply the posterior fossa dura. And here this is the sixth cranial nerve as it is entering from the Gruber's ligament and going lateral to the carotid artery. And this is again a superior view, and you see these various branches now more clearly. So the clival branches, the tentorial branches, and the inferior hypophyseal artery, as you can see here, that is going on to supply the pituitary. And you see all the nerves that we have already seen. This is the pituitary gland and the pituitary stalk. So this was the middle cranial fossa, whose main constituent is the cavernous sinus from the intracranial view. Now you can also approach this region, both the anterior and the middle cranial fossa, when you're going through the endoscope. So here you see the endoscopic view, and you see the various structures, the planum, the sella turcica, the clival part, and then you go on further. This is the opticocarotid recess, which you can see more clearly here. So here you see that this is the anterior intercavernous sinus, and it connects both the sides of the cavernous sinus. There is also a posterior intercavernous sinus, and this whole thing actually forms a venous ring around this sellar region, and that is the circular sinus, or as we like to call it, the venous circle of relief, because it kind of relieves the pressure in the, in the orbital compartment and transmit it to the cavernous sinus. So here you see the carotid artery. You see these branches of the carotid artery that is coming and supplying the capsule of the pituitary, and these are McConnell's capsular branches. This is, of course, the basilar venous plexus. And this is again a closer view showing the capsular arteries. This is the Vedian nerve. So this is the Vedian nerve coming from the pterygopalatine fossa and coming here and meeting the lateral part of the carotid artery. And this forms the Vedian nerve here. Now this is the medial part of the medial wall of the cavernous sinus. And here you can see these capsular arteries more clearly now. This is the lateral part of the cavernous sinus. This is the lateral compartment, the medial compartment. And the sixth cranial nerve will come into picture in this. And this is after all the bony work has been removed, and you see the different segments of the carotid artery, the optic nerves and the chiasm, the pituitary stalk and the pituitary gland, and the basilar artery after removing the clival portion. This is the sixth cranial nerve. Now, when you reflect, so if you approach the cavernous sinus from an endoscopic perspective, if you reflect the carotid artery medially, you will see these structures. So this is, of course, the venous plexus. Then you see the sixth cranial nerve. You see the V1, you see the V2, and you see these branches of the carotid that are coming laterally. And you see some fibers of, nerves. So you see these fibers. These are actually sympathetic fibers that run along the sympathetic plexus along with the carotid artery, and they go on to supply the V1. This is the third cranial nerve. This is the V2. And this is the carotid artery that has been deflected medially. So this is how you approach the cavernous sinus from the medial aspect. But the approach that we like for majority of cavernous sinus is an extradural approach to the cavernous sinus. As you can see, so many papers on the subject, and that has been written and described for the first time by Professor Goel. So this is our craniotomy. So you just have to expose this. The patient is placed in a lateral position. Sometimes we do a lumbar puncture, and that kind of relaxes the brain. And then you just peel off the dura. So this is how it is done. You peel off the dura from the middle cranial fossa base. This is the middle meningeal artery. And if you cut this region, if you coagulate and cut this middle meningeal artery, you will get more access, and it becomes easier to peel the middle cranial fossa floor. And once you peel this, you will start seeing the nerves. Once you open the lateral wall of the cavernous sinus, so you will see the V1, the V2, and the V3. This is the middle meningeal artery that has been cut. And going further, you can expose the carotid artery and all the contents by opening these various triangles. And again, this is a view that you can see from the surgical view. This is how it looks when you peel off the cavernous sinus dura. This is how you can enter. So this between V1 and V2, this is the region where you enter for, the trigeminal schwannomas. So for a tumor like this, we will come from here laterally, extradurally. We'll open the lateral wall of the cavernous sinus and then resect the tumor. And this whole thing can come out by just using this approach, as you can see in this post-operative scan. Now, these are another tumors. These are cavernous hemangiomas of the cavernous sinus. Again, we approach with extradural approach, and these are one of the most vascular tumors. They are, of course, also the most benign tumors, and you have to be ready and geared up for a lot of bleeding. But if you can manage to do these tumors, you get a beautiful resection, and the patient does well. And of course, the third type of tumors that are common are the cavernous sinus meningiomas. So again, there are different types. If they arise from the lateral wall of the cavernous sinus, as you can see in this case, they are very easily resectable by using this approach. Sometimes they occupy the whole contents of the cavernous sinus, and the management of this is quite controversial, whether you can just observe, and if necessary, you can just treat with radiotherapy. So now moving on from the middle cranial fossa into the posterior cranial fossa. This is the posterior cranial fossa. This is the Cavazis triangle that has been exposed, and you can go into the posterior fossa from here. So now here you can see as I was saying, this is between the V1 and the V2. This is the area where you enter, or between the V2 and V3, to enter into the lateral wall of the cavernous sinus and approach tumors. Here you can see that this is the infratrochlear triangle, and you can expose the carotid, posterior genu of the carotid, and the horizontal part of the carotid. As you can see in this exposure, the carotid can be exposed here. If you remove the ACP, you will expose the clinoidal part of the carotid artery. Now, coming lastly to the posterior fossa. Now, to understand the anatomy of the posterior fossa, you have to understand that there is a rule of 3 as described by Roton. So basically, there are 3 arteries that supply 3 compartments of the posterior fossa. So the superior cerebral artery, the ICA and the PICA, they supply 3 cerebellar surfaces. So the tentorial surface, the petrosal surface, and the occipital surface of the cerebellum. There are 3 parts of the brainstem, each supplied by these arteries. So the SCA supplying the midbrain, the ICA supplying the pons, and the PICA supplying the medulla. There are 3 peduncles again, each related to each brainstem parts. So the superior cerebellar peduncle related to the midbrain, the middle cerebellar peduncle related to the pons, and the inferior cerebellar peduncle related to the medulla. There are 3 fissures, the cerebello-mesencephalic fissure, the cerebello-pontine fissure, and the cerebello-medullary fissure. And each of these parts has a certain groups of cranial nerves, as we will see. So that is how you understand the anatomy of the posterior fossa. And of course, you have to know the petrous and the temporal bones, and with all its anatomy of the cochlea and the semicircular canals. That is actually a whole lecture by itself. So we will not go into that today. So this is the superior surface or the tentorial surface of the cerebellum. And here you can see how it is related to the colliculi. And this part of the cerebellum is supplied by the superior cerebellar artery and its branches. And this region, when you depress the cerebellum, it is a cerebello-mesencephalic fissure. And this is the superior cerebellar artery. You see it comes from here, branch of the basilar artery, dips here. So this is the 5th cranial nerve. It dips here into near the root entry zone of the trigeminal nerve, and then goes on medially to supply the colliculi and the cerebellar surface. So this is the first part of the posterior fossa anatomy. And you see the nerves that come here. So basically anteriorly of the third nerve, this is the fourth nerve and the fifth nerve that form this first part and related to that. Now coming to the second one, that is the petrosal surface of the cerebellum and the CP angle, which you see very here, the CP angle has an anterior limb and a posterior limb. And this is the region where it is the, most of the acoustic tumors and most of the other tumors of the posterior fossa can be approached from. So here you see the vestibulocochlear nerve complex. This is the flocculonodular nerve. This is the choroid plexus. And beneath here, you'll see the glossopharyngeal and other lower cranial nerves. So the 7th, 8th complex forms the neural bundle of the cerebellopontine angle or the cerebellopontine fissure. And the ICA, the anterior inferior cerebral artery, is the main artery that supplies the petrosal surface of the cerebellum. And here you can see this ICA that as it is looping and going all around and supplying this petrosal surface. And this is the 7th, 8th nerve complex. Of course, these are the lower cranial nerves. And when you approach it, the most common approach for this is a retrosigmoid approach. So you retract the cerebellum, and this is the anatomy that you will see. This is the superior petrosal vein. This is the 5th cranial nerve. This is the 7th, 8th cranial nerve complex. And here below is the lower cranial nerves. So going closer, you see these branches of the ICA, the labyrinthine branch and the subarcuate branch. The subarcuate branch goes on to supply the dura. The labyrinthine branch goes into the internal acoustic meatus and supplies the inner ear and the other structures there. This is the ICA as it is going. This is the choroid plexus and the flocculonodular lobe, which forms an important landmark to identify the facial nerve, which lies just superior to it. And here, of course, are the lower cranial nerves. Now coming down is the cerebral. So that was the cerebellopontine fissure. This is the cerebellomedullary fissure, where it runs between the inferior part of the cerebellum and the medulla. And the nerves of this region are the lower cranial nerves, as you can see here, and the hypoglossal nerve more anteriorly. And this vessel is the posterior inferior cerebellar artery, or the pica. And this, as you see, these are the lower cranial nerves. Again, this is the 7th, 8th complex. And the inferior part of the exposure gives you an exposure of the lower cranial nerves. When you look at it from a lateral perspective, now you see the different parts. So this is the midbrain, which has the 3rd, 4th, and the 5th cranial nerve here. This is the pontine part where you have the 7th, 8th nerve complex. And this is the medullary part where you have the lower cranial nerves and the hypoglossal nerve. So this is the superior cerebellar artery. Then you have the ICA here, and this is the pica as it is going on to form its cranial and caudal loops and going on to supply the cerebellum. And the last surface of the cerebellum is the occipital surface. And this is how you expose it, by a midline suboccipital approach. So of course, this is the tonsil. When you retract the tonsil, you'll be able to enter into the brainstem. And this is the branch of the pica as it is coming down from its caudal loop and then going on ahead to form the cranial loop here. And here you enter into the 4th ventricle. This is the inferior medullary velum. This is the obex, and this is the floor of the 4th ventricle. So this is a very commonly utilized approach for, cerebellar tumors, for 4th ventricular tumors like medulloblastomas, ependymomas. So this is the approach that we use very commonly and enter into the posterior cranial fossa. Here you can see the branches of the pica as it is going on to form its cranial loop. And now this is the parts of the brainstem in the posterior fossa. So this is the dura of the posterior fossa. This is the 4th ventricle. So this is here is the middle cerebellar peduncle. This is the inferior cerebellar peduncle, and superior is the superior cerebellar peduncle. So related to the midbrain, to the pons, and to the medulla respectively. This is the floor of the 4th ventricle. This is the 4th cranial nerve. This is the 5th cranial nerve. This is the 7th, 8th complex. Sorry, this is the 7th, 8th complex, and these are the lower cranial nerves that it is going down. And here you can see the C1 nerve rootlets and the C2 nerve rootlets, and coming down to the foramen magnum region. So this is the C1, and you see the vertebral artery as it is entering from the superior surface of the arch of Atlas and entering here into the posterior cranial fossa from its dural compartment here. And this is just the vasculature after the brainstem has been removed. And you see it beautifully here, both the vertebrals coming to form the basilar artery. Then this is the ICA branch of the basilar artery. This is the superior cerebellar arteries. Then the basilar bifurcating up into the posterior cerebellar arteries. And you see that this is the pica, which is a branch of the vertebral artery, and how it is closely related to the lower cranial nerves. This is the 7th, 8th complex. This is the 5th cranial nerve. And these are the vertebral artery as it is entering here. intermingled with the spinal accessory, and the spinal accessory runs posterior to it, and then you have the denticulate ligament, which also comes as an important relation. And this is lastly from the endoscopic perspective. So this is the basilar artery joined here. The vertebral artery is joined to form the basilar artery. This is the ICA, this is the superior cerebellar artery, and these are the nerves. So again, zooming the endoscope out, you see the whole perspective where you see both the carotid arteries with all the nerves. So this is the optic nerve, this is the pituitary stalk, the pituitary gland. Then you have the 6th cranial nerve, the 5th cranial nerve, the 7th, 8th complex, and the lower cranial nerves in this region. And also you'll see the 3rd cranial nerve here. So laterally, these are the lower cranial nerves and all the other nerves of the posterior fossa that you see here coming out from the brainstem from an endoscopic perspective. And lastly, this is the region of the foramen magnum. So this is the transition where the medulla becomes the spinal cord. It happens in this region near the C1 nerve roots come out. This is the transition zone between the brain and the spine. So this is an overview of the skull base anatomy that I have given you. I hope you have enjoyed it. And if you have any questions, I'll be happy to answer.
Okay, Ahmed?
Okay, Mar, are you there?
Yes, I'm here. So we are continuing. Thanks for joining us today. My name is Maureen Ball, and I'm the president of Dandy Club in Italy. We appreciate the opportunity to cooperate to create this cooperation webinar with collaboration with Dandy Club Portugal, Yemen, and the opportunity of cooperation with you, Professor John Bent from the Surgical TV. In the upcoming days, we are starting new projects in our club, so please stay updated with our social media pages. Now I want to introduce our speaker, Dr. Baran Salzar, that was serving as a president of the Ecuadorian Society of Neurosurgery, General Secretary of the Latin American Federation of Neurosurgeon, Fellow of Skull-Based Surgery in USA, Fellow of the American College of Surgeons, Fellow of American Academy of Neurosurgery, Chief of Neurosurgery of Military Hospital in Quito, Ecuador, member of the Committee for Therapy and Cerebrovascular Disease of World Federation, and Professor of Neurosurgery, undergraduate and postgraduate at San Francisco de Quito University and Central University of Ecuador. So thank you so much, and we are starting now.
Thank you very much for that kind introduction. I'm gonna share my screen. Okay. Is everything right? Are you watching the screen?
Yeah, that looks
Yes.
good.
Okay. Well, thank you. First of all, I would like to thank Moimbal, president of the Italian Dandy Neurosurgical Student Club, Ahmed Al-Ghameni, and all the organizers of this fine event, and of course, Neurosurgical TV and John Bennett. And in this occasion, I would like to talk about the principles for meningioma surgery, because I think this is the kind of surgery that is the first pathology that residents want to operate, and is one of the most gratifying when successful. And we just saw Professor Abraham, how beautiful can be these type of procedures. And of course, what he does is an expert level surgery. So I guess the main thing is to learn the principles for this kind of surgery. And when we talk about that, we know that Professor Al-Mefti published in his book the main steps for meningioma surgery, which are devascularization, detachment, debulking, dissection. And of course, Professor Silva, his fellow, created the acronym FIBER as a 5-step surgical strategy to take the meningioma out, which means the first time the surgery, the exposure, the bone removal, the arachnoid plane dissection, irrigation, and reconstruction. And of course, we know that Professor Lawton, Professor Martins managed to turn this number 7 into a magic number as their collection of books And as I saw it, it could be really easy to set up and include another 3Ds. But there are a lot of important steps for this meningioma surgery that could have been left behind. So that's what I did, these 17 steps, my own D rule for meningioma surgery that can be applied for every meningioma case. And it becomes a good exercise to review the principles, to know the important steps and some tricks for each type of meningioma. And this will make the meningioma a step-by-step surgery. And of course, some steps won't be applicable for all meningiomas, but that's the beauty of this exercise. And I would like to encourage these new generation of surgeons, residents, fellow students to understand the disease and to prepare in advance for that surgery. So all these steps that are required for a successful meningioma surgery, and to try to avoid any improvisations during surgery. So the first step would be a necessary component of the preoperative workup of meningioma that includes imaging, which means the diagnostic radiology. So the MRI, with and without contrast, is the gold standard for diagnosis and evaluation of meningioma. So it allows us to get a precise anatomic location of the tumor. The edema might predict tumor aggressivity and negative outcomes. We can see, for example, the degree of encasement of the vessels, like in this case, that they can be totally displaced or maybe encased by the tumor. And angio MRI, it's important because it gives us the information of their branches involved in the tumor, as well, and most important, the venous drainage. That is truly important to determine the number of tributaries to reach the sagittal sinus, to evaluate the patency of the sinus, to visualize the trolar de la vein, and of course, for parasagittal, falcine, and tentorial meningiomas can be assisted by this MRI venography, which can help us decide where we can do the approach. And angio-CT, it is useful when we correlate the 3D image reconstructions to facilitate the understanding of the bone deformity and its blood supply. Of course, in phagotemporal meningiomas, like in this case, you can do a cerebral angiography, a DCA, that it's usually performed in some cases to evaluate the arterial supply of the tumor, and the venous veins as a gold standard to assess the patency of the straight sinus, the transverse, the torcula. And we can see here, for example, how these meningioma and the straight sinus are partially infiltrated by these lesions. And of course, the inferior displacement of the cerebral internal veins. Of course, the collateral drainage. We can also use the CT scans that provide information about the extent of the bone involvement that is not well appreciated in MRI. Of course, the hyperostosis or maybe an osseous destruction. So intralesional calcification is the most significant predictable factor of slow tumor growth, whereas a hyperostosis and is adjacent of the skull and tumor is suggestive of a benign meningioma. And of course, we try to remove all the hyperostotic bone to avoid a new tumor growth. Our next step would be the DCA devascularization, which means the embolization, a preoperative embolization. So the debate concerning the preoperative embolization of meningiomas continues. We have some good things about it, induces necrosis, inflammation, softens the tumor. One can think less intraoperative blood loss and maybe shortened surgical time, but it also has some down things. You can have cranial deficit nerves. You can have a groin hematoma. It's another type of intervention. So we know that even though the main indications for embolization are ECA dominant blood supply, according to various papers, there are no clinical or statistically significant difference between blood loss, operative duration, gross total resection, postoperative complications, inclusive postoperative mortality. So we have to know all about the indications and especially the contraindications for this procedure. Of course, as we see here, for example, in large tumors invading the bone that are large hypertrophied feeders that are maybe some not reachable in any after an early craniotomy, it could be a place to do the preoperative embolization of these kind of tumors. Of course, there are some controversies about the material, the size of the particles, and even though the timing of the embolization. Our next step would be the drain, which means the lumbar drain. It is recommended in some cases like parsagittal meningioma of posterior fossa meningiomas, phacotemporal meningiomas. Of course, the main point here should be that the drain should be opened simultaneously when opening the dura, especially in posterior fossa tumors, to avoid a risk of any foraminal herniation. Our next step would be the disposition, which means the patient positioning. And these patients should be positioned to allow the surgeon to work ergonomically comfortable. So we can always try to use the gravity in our favor. So for example, in my preference, parasagittal meningiomas, Fox meningiomas, you can position the patient in a lateral or park bend position, especially for older, short neck, obese patients, and always with the tumor downwards. There are some alternatives as the Spetzler group, which they position the patient with the tumor upside up, and they tilt the head, but it is not something that I would use because I actually like to use the gravity in my favor. But it is possible, no? It's reported, it's published. For olfactory groove meningiomas, the patient can be positioned in a straight neutral position with an extension of the head so the frontal lobes can fall away from the anterior skull base. For some meningiomas, especially for less than 3 centimeters, the meningiomas, the patient can be positioned in a supine position. The head is elevated like 20 degrees over the cardiac level, rotated just 15 to 20 degrees toward the contralateral side of the tumor, and tilted a little bit laterally. So this position is helpful to use a supraorbital approach like Professor Yuha does it, and you can access and take small meningiomas from all the olfactory groove. For convexity meningiomas, for example, the shoulder, the main important thing is that the shoulder of the dependent hemisphere, it's supported with a large bolster, and the head is rotated according to the location of the lesion. As we see here, no great master of the semi-sitting position like Professor Sami, Tatajiva, Leal, Campero, they have shown us that for very big meningiomas, the semi-sitting position is an advantage because of the surgical field. Is always clean thanks to gravity, but it requires an experienced anesthesiologist to detect air embolism. And at least for myself, for the surgeon, it is harder because it can cause fatigue working with your arms outstretched. So it is truly exhausting. My presence, and at least for small tumors, I would prefer the supine position, rotating the head as much as I can, or tilting the patient in a park bend position. So it's a more comfortable position and there is no risk of air embolism. Our next step would be the drawing, meaning the incision. The main step for planning an incision are to perform sufficiently wide incisions of cutaneous flaps to avoid excessive head retractions, to preserve the myofacial and pericranial structures integrity, and preserve the vascularization of cutaneous nerves. So actually, we have to preserve both the superficial vascularization of the skull and its innervation, mainly the three groups, the anterior, the lateral, and the posterior groups. For example, regarding the incision, the bicornular incision is useful to reach the fronto-valsar or bilateral frontal portions to treat olfactory groove meningiomas, for example. And we know that, as Professor Speed and Professor Shah talked before me, a more posterior incision facilitates of harvesting a longer pericranial flap, and you don't need to use any kind of duroplasty with an exogenous material. A question mark incision is useful to access the temporal lobe, including the tip, may be used to access the middle or posterior the temporal bone, depending on how far behind you go, like in this case. So the base of the incision, that is the most important, it should be wide enough to avoid trying to preserve the superficial artery, the both of their temporary arteries of their branches. For example, when we use a C or horseshoe incision, we should have a base that is twice the height to avoid ischemia. And for Fox meningiomas, the incision is carried across the midline, so that the superior sagittal sinus may be exposed over the length of the bone and mobilized if it's possible or necessary. A vertical incision is less traumatic to the overlying muscles, maybe easier to get a watertight closure and faster maybe. So it is useful for small lesions in which there is no need to have a big duroplasty, a big pericranial flap. Of course, in the CP angle, we have different types of incision that we apply to a retrosig approach. We have the C curved incision. We have a linear incision, a lazy ace incision, or this modified reverse U incision that it's well used by the Professor Cohen. And this is interesting because in this paper, they compare the C-shaped incision against the linear incision. And the main thing is that for people that are obese, it is better to do a C incision because you can mobilize and you have more angle of attack than in a linear incision. It reduces the chronic development of muscle fibrosis and scars, reduces also the occipital neuralgia, and principal in the self-retraining retractors, reduces ischemia. Because as you see here, in these obese patients, they get this little bump of skin. So you actually cannot gain a wider exposure. So for these patients, obese patients, short-necked patients, it is better to do a C-shaped incision. Of course, there is another type of incision, the Hawkins incision, a bigger C-shaped incision. But what is the most important is to preserve the facial nerve when you perform your incision. And of course, according to this article published by Campero, he describes the zygomatic facial triangle, which is formed on the upper border of the zygoma anterior to the tragus 26 millimeters below of this point and 18 millimeters in front of this point. So this triangle is a safe zone of dissection. So if you go outside this safety zone, like in this case that was operated in another institution, there is a greater risk of damaging the facial nerve. And this is something that you have to know, that you have to be careful, and you cannot deliberately do an incision that will hurt the facial nerve. Our next step would be the design, which means the craniotomy. So bar holes can be placed over the sagittal sinus by controlled drilling, or they can be placed on one or to the other sides or both sides of the sinuses. The bone flap elevation can be done in one stage or maybe in two stages. This way, you can use to allow to dissect the first piece. Then you can dissect it from the sagittal sinus and then perform, the other side of the craniotomy, to knowing that you don't have any risk of damaging the sagittal sinus. The exposure or the craniotomy should be at least 3 centimeters around the margins of the tumor, which means we have to do bigger craniotomies. In some cases, like parasagittal meningiomas, the craniotomy can cross the midline, like in this case, that's the sagittal sinus and it crosses the midline and expose 2 or 3 centimeters on the other side. Or in some cases, you can also expose just the border of the sagittal sinus to avoid any venous lesions. Of course, if we're going to do the bifrontal craniotomy, after ligating a being bulking flap, we have to deal with the frontal sinus, demucalize it, cranialize it, and of course, the crista gallia is identified, resected, and of course, all the steps that we have to go to bifrontal craniotomy. Regarding the elevation of the bone flap can be complicated because this engorge anastomosis and by invasion of the tumor in the bone. So in these cases where we know that we have a severe hyperostosis, the craniotomy flap can be planned around the tumor by placing multiple bar holes and connecting them by rongers or by the motor or caissons, whatever, and a central portion of the bone can be left attached to the tumor, like in this case. For deeper lesions, like in this intraventricular meningioma, we can use craniometric points to confirm the nerve with neuronavigation and plan smaller craniotomies to reach, for example, in this case, the intraparietal sulcus to approach this lesion. And as you see, we got to take the whole meningioma out, and the patient had no visual deficit and motor deficits. Our next step would be the drilling. For many meningioma surgery, we need to drill the bone to get to the tumor. So, for example, as we saw in clinoidal meningioma, once the craniotomy is established, we proceed with the extradural work that leads to the removal of the anterior clinoidectomy. After that, the optic canal is drilled and decompressed, and the dural layer of the optic canal is open and locking the optic nerve, so we actually can extend our fill into the surgical, into the optic nerve canal and remove all the little tumor that can be compressed in there. Of course, for vestibular schwannoma, or meningiomas with auditory canal invasion, like in this case, we first have to drill the posterior wall of the fundus and identify the intracanal tumor to proceed with the dissection from lateral to median, hoping to preserve the 7 and 8 cranial nerves. Of course, in school-made meningiomas, we have developed some kind of approaches to access the clival, petroclival meningiomas to the different portions of the petrous bones, such as the anterior or the posterior petrosectomies. So it is important to use a lot of saline during the drilling to avoid heat lesion. Our next step would be the devascularization, which means an early transoperative devascularization. It's the early interruption of the blood supply that is critical to minimize the blood loss during tumor resection. So we know, for example, in the parafalcine meningioma or smaller meningiomas, the early devascularization can be achieved by opening the interhemispheric fissure and then to allow an early access to the base of the tumor adjacent to the fox. So we would start our surgery coagulating around the fox. Of course, for large meningiomas, the decision is initiated laterally, then debulking. And for some, we have to keep in mind that there are some callosal marginal branches that can be also on pericallosal arteries that we have to identify and preserve. Sphenoid meningiomas, we receive the main arterial supply from the middle and accessorial meningeal arteries, as we see here. So to get an early devascularization, we can use extradural approaches to the anterior middle fossa, as we see here, to identify, as Professor Shah said, the meningeal arteries. So we can use a transzygomatic with mini peeling approaches or very basal temporal approaches and proceed to do a mini peeling. For example, in convexity meningiomas, the coagulation of these hypertrophied and tortuous branches of the meningeal arteries is mandatory, and it's performed easily after the craniotomy. For example, in clinollar meningiomas, to the blood supply from the ethmoidal arteries, some dural branches, middle meningeal artery, as well as the meningorbital arteries, we can devascularize the lesion after identifying and counting the meningorbital band. Then we can go extradularly to expose the clinoid process, the anterior clinoid process, and coagulating the pretemporal subtemporal dura of the sphenoid. So, and for example, in olfactory groove meningiomas, conventional angiography is rarely required because of the major feeding vessels are the anterior and posterior ethmoidal arteries. And sometimes they are very small, so actually the DCA and embolization of this artery is not required. or maybe technically possible to do in some cases. Our next step would be the durotomy. So how are we going to open our dura? We can find microscopic, according to this paper, macroscopic or microscopic nodules at a distance from 1 to 3 centimeters of the side of the attachment of the meningioma. So what is this meaning? We need a wide surgical incision of the dura. So the dura is made with cut circumferentially around the tumor with a margin of 2 centimeters or maybe 3 from the last contrast enhancing component of the lesion. So the dura is coagulated and resected along the tumor. In parasagittal meningiomas, we can use and open in a semi-lunar fashion. In some cases, for example, in very big tumors, we can do a small durotomy and start later a debulking of the lesion. That means that we're going to open a little bit and then start to debulk the tumor, so to avoid that the whole tumor goes up in the air and starts to come out. And of course, we can always use some coronoids, some patties to protect the brain that is underneath to avoid any kind of lesion as we open the dura. There are few variations to open the dura in the retrosig approach. We can do it in a straight linear fashion, as Professor Tajiva does it, Sami does it. We can use a little C incision like Campero does it. And we can also use this kind of incision that it's along, it's not along the transverse and sigmoid sinuses. It's on the other side, so there is no risk of hurting them, of making any venous lesion of them. And then we can cut in a transverse fashion up to the transverse and sigmoid transition. The next step would be the delimitation of the tumor. And we know that during initial this dissection, we have and we try to identify the presence or the absence of an arachnoidal plane between the meningioma and the adjacent brain tissue. So what we do, or we try to do in all cases, is try to have this plane dissected around the tumor. We don't have to go deep inside, but it is helpful that we know and we try to find this plane around the tumor first. The next step would be disassemble. And this is what we have learned from Professor Goel, the art of breaking the tumor. And in some cases, like in these huge meningiomas that protrude the bone, even the skin, this extracranial component needs to be addressed first. We have to take it out, and we have to take it out to the level of the bone, so we gain time. The capsule is coagulated to decrease the tumor size. In very giant tumors, we can cut the extracranial, as we said, leaving the tumor at the margin of the craniotomy. And of course, be careful. We have to avoid in block resections of these kind of tumors because we can have a lot of cerebral damage if we try. Sometimes we have calcified tumors, and we will need to break the tumor in a piecemeal fashion using sharp blades, like in this case, with traction and contratraction maneuvers. Our next step will be the debulking. The debulking, it's fundamental for meningioma surgery, I believe. For lesions that are bigger than 3 centimeters, the debulking with the CUSA must be performed to facilitate the dissection of the tumor capsule. And following the internal debulking, the dissection can proceed in a circular fashion, alternating from lateral to medial until the deep portion of the lesion can be reached. And you can also use scissors or blades to initiate the debulking process. And this is how it should be after you have a well done and meticulous debulking. So you can have a big cavity, and you can have, around the capsule that it's way easy to manipulate. You can have also también to debulk the tumor, the tumor to use cautery burners. And after this, the next step would be the dissection, which means the arachnoidal dissection. And this is something that we have learned from Professor Al-Mefti, as we see in one of his videos. And we see how the arachnoid plane must be maintained such that the arachnoid is dissected away from the tumor into the brain with this peeling away maneuver that is done with traction and contratraction maneuvers. So it takes this arachnoid from the tumor to the brain. And of course, in parasagittal meningiomas, in this video also from the Alma articulation, we see the Sujita Kobayashi maneuver, which is to dissect these veins from the underlying cortex and arachnoid so we can make them free and be able to be mobilized, allowing us safe mobilization so we can enter the interhemispheric fissure, for example. And as Professor Al-Mafti does it, we try to replicate it. And, you know, it's very useful because we preserve and we have to preserve the veins. In some cases, for example, like this, when the tumor has violated the pial surfaces, we can use gentle dissection with bipolar coagulation that is done to separate the capsule from the brain tissue. And let us remember that meningiomas without arachnoidal plane of dissection and pial invasion might be associated with more complications and may have different cure rates and worse outcomes. So we can also try to use a coagulation of the capsule to try to shrink it and to create a wider arachnoidal plane if we have to. There are some reports about vacuum-assisted in-block resection technique. This can be done in medium to large meningioma convexities. Actually, I don't like to use it because I would prefer to debulk first and to try to have a less contused surgical parenchyma. So at least for me, this is a little too invasive, but you know, it's described, it's published, and if you have the instruments, maybe you can try this. Of course, when the surgical plane is obtained, this space between the arachnoidal plane, we can help to maintain this plane using cottonoids or patties that are placed circumferentially around the tumor and the lesions. Of course, this is the water dissection techniques, as seen this here in the collection of videos of Professor Juha Hernes-Niemi. It's a very simple, inexpensive, and effective way to open a cleavage plane between the extraparenchymal masses and the brain. Of course, if you don't have that technology, you can use this one. That, of course, it's manually with a syringe following the arachnoidal plane. But all stratagems are valid as long as they help us to resect the tumor more efficiently. We can use stitches to mobilize the tumor. So the capsule is separated from the brain tissue, respecting the arachnoidal plane, always towards the resection cavity. So we try to coagulate the capsule, try to shrink it, try to mobilize it, and identify the neurovascular structures so we can easily protect them and preserve them. Our next step would be the disconnection. That means in block versus piecemeal disconnection. Disconnection of the neurovascular structure, of course, is mandatory. For example, in clinodal meningiomas, the tumor is separated from the adjacent ICA, with sharp dissection, with big magnification. No artery is sacrificed unless the vessel is confirmed to be a tumor feeder. And of course, we have to maintain the veins. We have to preserve the veins. Meningioma is a vein surgery. The main advantage of in-block resection in some cases appears to be lesser bleeding and shortened operative time. This is done when possible, and especially for me in small meningiomas. For lesions larger than 3 centimeters, like in this case, to take the lesion in block requires too much manipulation of the adjacent parenchyma. So there may be ischemia, epileptic seizures, edema. So we have to avoid dissecting the meningioma with our fingers. Some people still do that. We have to avoid this. And of course, aggressive manipulation of the brain will leave a traumatized parenchyma like we see here in this case, with a huge cavity inside. So to get a trophy, a meningioma as a trophy, it's not my way to do it. I would prefer to do it in a piecemeal dissection that is mandatory. For example, where the in-block resection is not possible, and for meningiomas that are bigger than 3 centimeters. So we, of course, in skull-bed deep meningioma lesions, we can and we should done it in a piecemeal fashion. Our next step would be the dura implantation. That means that tumor cell infiltration of the dura is quite common and may be found even in 2/3 of the cases. And as we see here, to accomplish a resection of the dural tail, like in this case, we see that it should be 2 centimeters away from the last enhancing part of the tumor. But in this case, we see here, for example, that this dural tail, it's maybe 1 or 2 centimeters away from the main base of insertion of the tumor. So we have maybe 2 centimeters in front, maybe 1.5 centimeters behind. So if we have and we need to do a Simpson 1 resection, we have to make and we have to take this into account, which will mean that we will need a bigger craniotomy, that we will need a bigger durotomy, and that we have to see and even confirm with neuronavigation that at least from this last enhancing point, we will calculate a 2 centimeters edge of free space that we are going to take the dura out. So that means that we will have, or we will have to have a very big pericranial flap, or if you don't have, well, something to do a duroplasty. The recurrence, for example, in falcic meningiomas is related to the diffuse presence of the tumor between the leaflets of the fox. And so an increased extended resection of the fox surrounding the tumor, like in this case, as we see here in this picture, it is possible, and the best outcomes minimize the risk of recurrences and progression. So this is what Professor Almefti called the grade 0 resection. And of course, as Professor Almefti do it, we do it also. So we try to take the tumor out, we see the hole in the dura, and of course, we do a very big and extended fox resection as high as possible, as low as possible, to avoid any risk of any recurrence. And of course, we can see here in some schematics of the Neurosurgical Atlas by Aaron Cohen that some of them have a tentorial, for example, implantation, and that could be coagulated in most of the times, or as he does it, you can cut the tentorial in a way, preserving the fourth nerve, and to take it all out to reduce the recurrence in these kind of lesions. The next step would be the duroplasty. We have a lot of things to do a duroplasty. We have pericranium, we have facial lata, we have the temporalis fascia, or pericardium, or synthetic dura. We should try to achieve a watertight dural closure, which is important to all patients, with residual disease, high-grade lesions, and of course, people who are going to have maybe an adjuvant radiosurgical therapy. And of course, in clival, petroclival meningiomas, it is not possible always to do a duroplasty. For this reason, it's necessary to perform a vascularized gallofacial flap. So this flap can be directed and cut lengthwise so that it can be rotated into the tip of the flap and can reach the petrous apex. And then, of course, we can use some abdominal fat and some kind of surgical ambient glue and all the sealants to avoid any CSF fistula. Lastly, deformity, which means the cranioplasty. So it is fundamental to have all the different materials that we can perform a cranioplasty if our intent is to make a Simpson 1 resection, which means take the bone out. So cranioplasty can be made with a titanium mesh, PEEK, or methyl methacrylate. So, and of course, all affected bone must be discharged. And I would add nowadays an 18D will be the devices that we need to have all the devices into account. We need to have the CUSA, we need to have the plasma coagulator, you need to have the microscope. If you don't have all the devices that you need, you won't do any any good surgery, and to perform better. Some clinical cases, very fast, as we presented before. This was a 52-year-old female with a middle third Fox meningioma. We always do this analysis, these 17 and now 18 steps to elaborate our game plan to treat this meningioma. So in this case, the patient was placed in a lateral position with the tumor side down, of course. And actually, I would prefer only to tilt the head 15 degrees up, not as Professor Spetzler, as he does it like maybe 45 degrees. I guess there could be a compression here in the main veins, so actually I do it only a 15 degrees tilt of the head, and for me it's quite sufficient because it allows me to be and only expose a few millimeters of the sagittal sinus, so I have my angle of attack directly towards the Fox, and I don't need to make a bigger craniotomy and cross the sagittal sinus. And it is sufficient to gain access to the interhemispheric fissure and start doing all the bulking and all the steps that we already talked about to actually gain a control of the lesion, debulk it, to take the feeders, and of course, without this position or with this position, we don't need to use any kind of cerebral retractor. We just use the gravity. And of course, at the end, removing all the Fox with this margin of the security margin as low and as high as we can to achieve a great cerebral resection. We can see here the pre-op and the post-op, the patient without any kind of focal deficit. Another case, this was a 44-year-old female patient that debuted with surgical focal seizures with episodes of sensory dysphagia. And we can see a left parietal convexity meningioma that compresses the Wernicke area, and a large dural tail, as we saw, that extends outside the tumor implantation of the intratumoral calcifications, as we hear in the CT scan, a little of a hyperostosis of the bone adjacent of the tumor. As always, we did this exercise. And in this patient, we position our patient in the usual manner for this kind of for lesions, in a park position. Oh, in this case, we just rotated the neck. She had a long neck, so we just rotated the head. So we use neuronavigation, specifically in this case, to mark the anterior and posterior limits of the dural tail, so we know how far we can extend our incision and to be able to take all the dura out and do a very big duroplasty. Of course, the usual places, the craniotomy, the dissection, and as we tried to take the bone out, we saw that, of course, the bone was here already infiltrated. The coagulation of the hypertrophied and tortured branches of the meningeal arteries that are really done really easily after we already opened the craniotomy. We spent a lot of time there trying to take all these arteries to reduce the bleeding. So we made a big durotomy, basing on our findings with the neuronavigation. Of course, the tumor was debulked in the usual fashion. We use watertight dissection, respecting the arachnoidal plane, and a Simpson one was achieved, taking the whole tumor out, and later we did a duroplasty. Of course, in this case, we also drilled the infected bone to take the pathology, and of course, we try the rest of the bone was in a good condition, so we use it once again, and of course, a duroplasty with a cranioplasty with a dural mesh. We can see here the pre-op and the post-op, and the patient without any kind of deficit. A last case, 78 person that was diagnosed for this small left frontal meningioma since 2015, and that had no change significantly in 7 years. He is asymptomatic. And we always have to understand the natural history of the disease before deciding any treatment. So because we operate in patients and not images, and sometimes the best treatment is just to observe. So, and this meta-analysis concluded that these annual volume changes of more than 2.1 centimeters, cubic centimeters a year was the strongest indicator of symptomatic progression of the patient. So younger age, absence of calcifications, T2 hyperintensity were associated with a faster tumor growth, velocity, and greater radiological tumor progression. So we have to know the natural history of the meningioma. And of course, this is another case that it's truly inspiring because this patient came for a second assessment from another institution because he was promoted that he should have surgery with these lesions. He has mild headaches without any neurological deficit. A small incidental anterior floor meningioma was evident in MRI. So we can discuss the things that were not properly done in this case. For example, he had a radiological report that described this lesion as a parasagittal meningioma. That means that's completely wrong. It's an anterior skull-based meningioma. Surgery was indicated even though this patient was asymptomatic without any evidence of radiological tumor growth with an extremely small lesion. So this patient, of course, didn't accept surgery and was proposed even then to have radiosurgery. So as a conclusion of these patients, we see all the things that shouldn't be done in a patient. So you can not trust the radiology reports as always. You have to assess your image yourself, and you have to decide an indicated surgery, but you, of course, have to know first the natural history of the disease. What will be my conclusion and message to young neurosurgeons? That it is always important to develop a work plan, methodically analyze every case, and carry out a step-by-step surgery that can be reproduced in all cases. Of course, I would like to thank you and invite you to our international Congress here in a few days from 12 to 15 of March and here in Quito, Ecuador. We will have a lot of main professors like Professor Borba, Campero, Juan Luis Gomez Amador, a lot of people from South America. And of course, Ecuador, it's a nice place to get to know. We have the Galapagos Islands. So everyone invited, I invite you to come. It's going to be a nice meeting. Thank you very much for your attention.
Okay, Ahmed.
Yeah, I would like to thank Professor Baron Salazar for this amazing presentation. And I would like to check if Mar Imbal around or not. Are you there?
Yes, I'm here. Again, I also want to thank to Dr. Baran Salazar that gave us this amazing lecture today, and of course all of the other doctors. It was a great opportunity to create this collaboration between different clubs around the world. And thank you for John Bennett that gave us the opportunity to use the platform of the Neurosurgical TV. It was our pleasure.
Okay, we have a question, I believe, Ahmed. Could you look in the chat there? Do you see it, Ahmed?
Questions, I think.
Okay, Byron, it says, thank you very much. What do you think about the intratumoral injection of hydrogen peroxide in meningiomas?
Well, I guess it is a strategy. We know that it's not a sterile solution, and it is and its use is related to little microthrombosis. So I would prefer not to use it, but if we encounter a tumor that, for example, had no indication for a preoperative embolization, we try to first get an early devascularization, and we actually couldn't done an effective job, and it's bleeding. The patient starts to have hypotension, and the anesthesiologist needs to bring some blood, and the patient is not well hemodynamically, I guess it is an option that we can use. I have used it. It have served me well. But every time I try not to use it. But if it's necessary, you can use it. Yeah, it's a strategy.
Okay, very good. I didn't realize more. That was your question. Okay, any more questions from the panelists?
I can see here a question regarding to the devascularization of tentorial meningioma, how we can do it, as someone was asking.
Yeah, actually, you need to have a good exposure. So if you are going to have a tentorial meningioma, it would depend of the kind of exposure that you did, your approach, and of course, if you are going to do a supracerebral infratentorial approach, for example, you need to go as far as high as you can. Maybe you have to expose maybe 2 or 3 centimeters of the transverse sinus. If you're going to do it bilaterally, like the Stein approach, you have to be careful about the torcula. And of course, if you are going to do it in a semi-sitting position, you have to have a lot of good anesthesiologists with you, because they have to monitor your air embolism. And once you identify the area that is taken by the tumor, you have to start to coagulate. And then after you can delimitate the area of that is embraced by the tumor, you can go maybe a centimeter outside this area and try to start to take the tentorial out. And the most important thing would be to have and to take care of your 4th nerve. So actually, I will do that at the end of my resection, of my dural dissection, my tentorial dissection. So actually, I can go inside, take a little care to see well, to identify my nerve and cut, always knowing where the 4th nerve is. If you don't know where it is, I won't cut it. I will try to look for it once again, and then I visualize it and then start cutting once again.
Very good. Any more questions from the panelists? Last chance before we close it up. Okay, very good, Byron. Thanks for your time. And Ahmed, any closing remarks?
I would like to thank you, Professor John, for this great opportunity to get Neurosurgical TV as a platform which is the most famous platform in the world. So we are most appreciated for this opportunity, and we wish to meet you soon, of course.
Okay, any more plans in the future? Do you have any more webcasts scheduled?
Of course, maybe after 2 weeks from now, it will be about the story or something like this.
Okay. Okay, we look forward to hearing news of that. Okay, thanks everybody and good night.
Thank you, John.